Yeah, good evening, everyone. So that was an extensive discussion of waveforms, drugs, and instruments. So I'll be covering the ECG and ABGs. So this is something that we normally do at the bedside. Let's do it in a systematic manner. Okay. So first, I'll be spending some time on the two slides, a stepwise approach. How do you first approach when you're given an ECG? First, check the name, date, whether the patient's age, what is the indication, any previous ECGs and subsequent ECGs that are available. The other most important thing is the calibration, whether it's calibrated or not. What is the speed? Okay. So if it's calibrated appropriately, the x-axis, the timing will be one small square that is equal to 0.04 seconds, that is 40 milliseconds. And if it's a large square, it's 0.2 seconds, that is 200 milliseconds. In the vertical axis, one small square is equivalent to 0.1 millivolt and one large square, which is equivalent to 0.5 millivolt. Okay. So next, you will have to assess the rate. So how are you going to determine the rate? So you will have to check in for the RR interval. So within the RR interval, how many large squares are there? 300 divided by the number of large squares. Or if you are taking into account the small squares, 1500 divided by the number of small squares. So that is going to be the rate. What if your RR intervals are irregular? So take the long strip and see how many RR intervals are there. Number of RR intervals on the long strip multiplied by a factor of 6 gives you the rate. Okay. So that is about the rate. Next, come to the rhythm, whether it's regular, irregular, regularly irregular, or rhythm you'll have to interpret. Next comes the axis. Okay. So axis, how are you going to interpret? A short method is to look at the lead 1 and AVF. Okay. In the lead 1 and AVF, it is positive. Lead 1 is positive. AVF is also positive. That's the normal axis. That is between minus 30 to 90. If lead 1 is positive, AVF is negative, it's a possible left axis deviation. Lead 1 negative and AVF positive, it's right axis. Okay, both negative, it's extreme axis deviation. So then come into each and every wave specifically. Look at the P wave. P wave morphology, height, and then you'll have to look into what is the size of the P wave. Then PR duration. So if you look at the PR duration, it is 0.12 to 0.2 seconds. That means it comes within one large square. So that is the PR duration. Then look at the QRS. QRS is 0.08 to 0.12 seconds. So that means it comes within three small squares. Okay. Then look at QT interval. Okay. When you're calculating the QT interval, it should be 450 milliseconds. So we already saw, so one large square is 200 milliseconds. So you're almost looking at two large squares. Okay. If it is beyond 2, then you're dealing with something like a QT, long QT syndrome. Okay. Then look at T wave, whether it's tall or inverted. Then look at the J point, which is the junction between the S and the ST segment, whether it's elevated or depressed. Okay. Next, the U waves. Okay. So, and then when you're dealing with acute coronary syndrome or myocardial infarction, you will have to mention which area is involved. Okay. So, which leads are involved denotes the area of involvement. In fact, that in turn denotes the arteries that are involved. So if we are talking about AVR, if there is a ST elevation in AVR, then the left main coronary artery is involved. One AVL, it is high lateral, high chances that the left circumflex is involved. V5, V6, left circumflex. Okay. 1 to 4. 1 and 2, it is septal, LAD. 2 to 4, it's anterior, LAD again. 2, 3 AVF, it's inferior, mostly the right coronary artery or the posterior descending artery. So mostly the right side is affected. V7, 8 and 9 is posterior MI. Okay. And V4R is right ventricular MI. So what is V4R? So V4R is nothing but V4, that is the lead, instead of placing in the left side, that is left fifth intercostal space in the midclavicular line, if you place it in the right side, there will be a ST elevation. So that is more specific for a right ventricular MI. So this is the basic slide wherein you can interpret every ECG by this way. So when you're the same thing, so every aspect when you're interpreting, you'll have to look into the rate, rhythm, axis, interval, P wave, whether it's a broad notched one or a tall. If it's tall, it's a P pulmonale, wherein the right atrium is involved, enlarged. Broad notched is LA enlargement. And then QRS, whether it's narrow or broad, and then look at the bundle branch block pattern, whether there's any hypertrophy, ST segment elevation, depression, or whether it's a pericarditis. T waves, you'll have to see in the chest leads, if it's more than 10 millimeter, and the limb leads, if it's more than 5 millimeter, it is significant. Okay. U waves and the QT interval. So whenever you're presenting an ECG, mention the rate, rhythm, key abnormalities, and then final comment on the ST T wave segment, and then mention your final diagnosis. Okay. It doesn't end with there. Then you will have to come to the etiology and then treatment as well. So anybody who wants to try this, a 47-year-old lady who presents with intermittent episodes of palpitation. So this is the ECG. Here the rate, I see large squares 3. So 300 divided uh, uh, by 3. So I have a rate of around 100. It's regular rhythm, 1 AVF. Okay, 1 I see a positive deflection, AVF I see a negative deflection. So this is left axis deviation. And then I see the PR interval. Okay, you look at P wave and QRS. Okay, the P and the QRS is very close together. So there's a short PR interval, and there is in some leads you can see the QRS is slightly wide. Okay, and the most obvious thing that you can note is a slurred QRS. Okay, which is a delta wave, which is diagnostic of a WPW syndrome. Okay, next the discussion would go into the etiology. So how does this happen? It can be congenital and abnormal, the Kent connection between the atria and the ventricle. And when this happens, it can be a orthodromic conduction or a antidromic. So when this is happening, why do you have a short PR interval? The short PR is due to faster conduction along the accessory pathway. Okay, so that is the reason why the travel time between the impulse travel time between the atria and the ventricle is decreased. Okay, next, why do you have the slurred QRS? Okay, early depolarization of the ventricles causes along the accessory pathway causes a slurred QRS complex. Okay, and you can also have altered ventricular repolarization. So when it is a orthodromic conduction, you'll have a narrow QRS. If there is an antidromic, that is a reverse conduction, then you will have a wide QRS. And sometimes you can have irregular QRS complexes that can be resulting in pre-excited atrial fibrillation. So how will you treat it? So next aspect would be treatment. So if it is a stable SVT, AF. Okay, if it's a SVT, try vagal maneuvers, then adenosine. So if it's AF, you can give procainamide or ibutylide if it's stable. If it's unstable, synchronized electrical cardioversion. Always you have to mention, you should not mention these drugs, okay? AV nodal blocking agents like if it is atrial fibrillation, adenosine should not be given, verapamil, dilzem, beta blockers, digoxin. So these drugs are contraindicated because it will worsen the conduction through the accessory pathway and cause ventricular fibrillation. And the definitive therapy would be electrophysiological study with ablation of the accessory pathway. So that is going to be curative. Okay. So next ECG, a 45-year-old man, known diabetic hypertensive, presents with left-sided chest pain, nausea, and dyspnea. So this is an EC1. So anybody who wants to, yeah, right. Some of them I have mentioned it. So this is a ST elevation MI, which is involving the inferior leads. So always, even if you know the diagnosis, just go stepwise. Rate, rhythm, axis is normal, ST elevation in lead 2, lead 3 AVF, and ST depression in V2 to V5. It's a acute inferior wall MI, okay, with an ST elevation MI. So how will you go ahead and treat this? Urgent revascularization, PCI or thrombolysis. So regarding ST elevation MI, you need to know what is the timeline of the ECG changes. So first you'll have the peak T waves followed by progression of the ST segment elevation. Then there'll be loss of R wave. There'll be loss of R wave and Q wave formation. Okay. Then you'll have a T wave inversion, and the last one would be established Q waves. Okay. And normalization of the T wave. So this happens from minutes to days to weeks. Okay. And also the timeline, what is the when will you thrombolyze if you don't have a PCI facility, and what will be the time duration if you have to do a PCI, or if you're going to transfer the patient to a PCI center? So those will be the questions to you. 79-year-old male, 45 minutes after receiving thrombolytic therapy for acute MI. So currently he is pain-free. You take an ECG and you find this. So what is the diagnosis? Yeah, I see Dr. Priya Tiwari answering it right. So rate, rhythm, again, axis, there is absent P waves, okay, and wide QRS, okay. This is a accelerated idioventricular rhythm. So this patient has underwent thrombolysis. So this is something that is a reperfusion rhythm, most commonly seen post thrombolysis. Okay, the rate is usually between 40 to 100 per minute. It is slightly faster than an ventricular escape rhythm. What is an escape rhythm? Some conditions like hyperkalemia or some calcium beta blocker toxicity and all, the AV and the SA node may not be functioning. The ventricle will be kind of generating the impulses. So that time you have a ventricular complex, that is this kind of a complex with a slow rate. Okay, that is a ventricular escape rhythm. So it will be faster than an escape rhythm, but slower than a VT. Okay, the QRS is wide, more than 120. It almost resembles a LBBB or RBBB pattern, and there can be fusion or captured beats as well. Okay, you don't have to treat this. It automatically resolves in minutes without therapy. Next one, a 50-year-old male presented to the ED, feeling uncomfortable in the chest, some tightness, diaphoresis. Okay, he's somebody with thrombophilia, and on therapeutic anticoagulation. Warfarin has been missed for a couple of weeks. And then when he presents to the ER, the heart rate is 60, BP is 168/88, respiratory rate is 28, he's afebrile. This is the ECG. So anybody who wants to diagnose? Pericarditis. Okay, I see one answer, pericarditis. Okay, so stepwise, rate, rhythm, and then axis, it's normal. One AVF is kind of positive, normal axis, and then PQRS narrow, and then I come to the ST wave changes. There is ST elevation in V2, V3, and V4. Okay, is this a normal ST elevation which we see in our ST elevation MI, or is it something different? And when I look at the ST, it is followed by a T wave inversion. Okay, what is this? You cannot miss out this. Somebody says D winter. Okay, so this is a STEMI equivalent. You have to know certain ECGs which are very, very critical in which need to be diagnosed immediately, because the intervention needs to be done immediately. These are the STEMI equivalents. Okay, the D winters, Wellens. Okay, new onset LBBB, hyperacute T waves. So these are the STEMI equivalents which you can never miss in an ICU. So what is Wellens syndrome? Wellen syndrome is nothing but here there is biphasic T waves. Whatever you're seeing is biphasic T waves, which is denoting a critical stenosis of the left anterior descending artery, which denotes a large anterior wall MI. Okay. The Wellen syndrome can be of two types. Type A is the biphasic T waves, and the second one is a deeply inverted symmetrical T waves. So this ECG is also a Wellen syndrome. So it is of two types. So this is symmetrical T wave inversions, which is more common. And whatever we have seen is the biphasic T waves. Okay. These are the other STEMI equivalents. So this is the conventional ST elevation MI where you can see this pattern. Whatever you're seeing here is Wellens A, that is a biphasic, and this is symmetrical T wave inversion. D winters is something that you should not miss, wherein there is a upsloping ST depression in V1 to V6 and a positive symmetrical T wave, which is in an SVR and AVR, you have a ST elevation more than 1 to 2 millimeters. So this is something D winters you should not miss. And the other one is the hyperacute symmetrical T waves. Okay. And LBBB, new onset LBBB, how will you diagnose? You have a wide QRS. So if it is a concordant ST elevation, concordant ST depression, that is, you have a positive wave and your ST elevation is also on the same side. So it's a concordant ST elevation of more than 0.1 millivolt, ST depression of more than 0.1 millivolt. Okay. And if it's discordant, it should be more than 5 millimeters. Okay. So that is something. And this is a shark fin pattern. Okay. So these are something that you should never miss. So this ECG, 16-year-old girl brought to the emergency department after sudden syncopal episode during school competition. Bystanders report brief twitching movements, initially thought to be a seizure. She regained consciousness spontaneously within a minute and felt fine later. So family reveals a sibling who died suddenly at the age of 18, okay, during a sports activity. So anyone who wants to try? Okay, I already see somebody writing, Dr. Deepak, long QT. Okay, very good. So here, the history is very typical. Okay, so going step by rate, rhythm, and then you see P wave, PR, QRS complex, and then you come to the QT. QT is definitely prolonged, okay? So the QT interval is definitely prolonged in this. Along with that, you also have some T wave inversions in multiple leads, V2 to V3. So you mention your findings and then your final diagnosis. It's a long QT. Why could this occur? It can be due to hypocalcemia. Hypokalemia also can present with this, hypomagnesemia and congenital. In this scenario, the history is very typical of a long QT syndrome, which is congenital. Okay, congenital variants, you have the Jervell-Lange-Nielsen syndrome and the Ramonowitz syndrome. So how will you diagnose? What is the score? This is the Schwartz score, okay, wherein you have the typical ECG findings, clinical history, and family history. In the ECG, you can find the QT that is prolonged, and then you can also find these abnormalities. Here, we also saw some T wave abnormalities, T wave alternance, notch T waves, and then syncope, congenital deafness, and family history, unexplained sudden cardiac death. So these are the other things that you can look into, and you can score. If it is more than 3.5, then it is diagnostic of a long QT. The drugs which can cause quinidine, procainamide, amiodarone, sotalol, electrolyte abnormalities. These patients are at very high risk of developing sudden cardiac death and Torsades de Pointes. Okay, treatment will be, you have to plan for a implantable cardioversion and defibrillator. Okay, and immediately if you want to give a drug, beta blocker is something that can be tried, but ICD insertion will be the definitive therapy. So long QT congenital aspects, if you are looking into three types, something that you can know. Three types. First two are related to potassium channel abnormalities. Three is due to sodium channel abnormality, and pharmacological therapy would be beta blockers and mexiletin. Okay. So sixth ECG. So 60-year-old man, diabetic, hypertensive, sudden chest pain, palpitation, sweating, 150, blood pressure, comes to the ER. I think this is an easy one. So this is a obvious ventricular tachycardia with pulse. So whenever you're talking about VT, you will have to mention with pulse or without pulse. That is something very important. So if the patient is unresponsive, no pulse, then you say VT without pulse. So broad complex tachycardia, obviously the heart rate is more than 150. The QRS is wide. And then how will you? And there is a positive deflection, that is concordance of QRS, that is all pointing upwards in the chest leads. Okay, immediately what will you do? The patient is stable or unstable. Okay, the patient is obviously unstable, chest pain, palpitation, symptomatic. Okay, so immediate synchronized cardioversion with always when you're mentioning cardioversion, mention synchronized cardioversion joules. Okay, 100 joules with sedation. Okay, and if the patient is stable, what will be your choice of therapy? Amiodarone, lidocaine can be. So how will you differentiate VT from SVT will be your next question. Yeah, that's monomorphic VT, somebody has mentioned. So this is the morphological criteria to differentiate between aberrant SVT, SVT with aberrancy and VT. So this is the Brugada algorithm. So you had this positive concordance in this patient actually. So you can also have negative concordance. That is all the chest leads becoming kind of more negative appearance. So it can be either a positive concordance or a negative, but it is looking like a absence of RS complex. You don't have a proper RS complex. So this is a diagnostic of VT. Sometimes you might have this kind of a pattern wherein here you'll have to check. So if you don't have this proper absence of RS complex, then if you are looking into some ECG which looks like this, you look into the RS interval. Okay, if the RS interval is more than 100 milliseconds, then you're dealing with VT. Okay, if you have some P waves, okay, even these criteria is not met, you have some P waves which is not followed by there is a obvious dissociation. There's no P wave is merged here. Here it is appearing just below the QRS. So there is a obvious AV dissociation. Then you're dealing with VT. You can have fusion and capture beats also. The fusion beats and capture beats look like this. Okay, so if this criteria is there, then you're dealing with VT. If all this criteria is not met, then you're dealing with SBT. So when you're looking at some ECG which has wide QRS, also note you'll have to remember the criteria for RBBB morphological criteria, LBBB, the criteria. Okay, so these things you have to remember. A 32-year-old man is brought to the emergency department after being found unconscious at home. Wife reports he was sleeping when she heard a loud gasp followed by a brief shaking movements. He regained consciousness within a minute but appeared confused. Echo drop is normal, but you find this ECG. So any answers for this? Yeah, Dr. Parvati has answered it rightly. I'm happy that many of you are answering it. So go step by step. Rate 100, regular rhythm, normal axis, and you find some curved ST elevation. Okay, is it normal? No, it is a curved type ST elevation. Okay, in typical V1 to V3 leads. Okay, followed by inverted T waves. It looks more like a Wellens, but it is not. Okay, so and there is also a RBBB pattern in this. Okay, this is Brugada type 1. Okay, here you find one more important thing is echo and drop is also normal in this. So mostly this is here you find the ECG and the enzymes most of the time normal, and it is also a sodium channel abnormality. Patients are at very high risk of developing a ventricular fibrillation and sudden cardiac death. And treatment is implantable cardioverter defibrillator. Okay, and always avoid flecainide and procainamide. Okay, and the treatment isoprenaline and mexiletine is something that can be given. So these are the various types of Brugada. So this is type 1, which we had seen the curved ST elevation more than 2 millimeters. Sometimes you can have a saddle-shaped ST elevation more than 2 millimeters. So this is the saddle-shaped one. And if this is not meeting the 2 millimeter criteria, this is less than 2 millimeter, it falls under the third type, which is very difficult to identify actually. So next, a 58-year-old man recovering from abdominal surgery, laparotomy for abdominal intestinal obstruction, is being assisted out of bed for the first time. Within minutes of standing, he developed sudden onset shortness of breath, chest pain, and lightheadedness. Most commonly, we receive a med call for such patients, post-operative patients after mobilization, developing breathing difficulty and all that. So this is a very typical ECG. So anyone who wants to interpret this? RBBB S1 Q3 T3. Yeah, somebody said P, right? Okay. So stepwise, go ahead. P, QRS, and then rate, rhythm, right axis deviation, and V1. Whenever you see a R wave, RS or this pattern, RBBB kind of pattern, you will have to think of something very important, okay? Something that could be, and the history is very typical, okay? So look into lead 1, S wave, lead 3, Q, and then there is a T-wave inversion. So this is S1, Q3, and T3, T-wave inversion, and you have a RBBB pattern. And there is a right axis 1 and AVF, you see a right axis deviation, and T-wave inversions is an additional finding in multiple leads, okay? So this finding is very typical of pulmonary embolism, which you shouldn't be missing in your exam at all, okay? So next one, 72-year-old male, hypertensive, CAD, metoprolol, presents to the emergency department with fatigue, dizziness, a near syncope over the past day, mild shortness of breath on exertion. So this is the ECG. This is something very typical. Anybody who wants to try? Junctional heart block, complete heart block. Yeah. Okay. So this is this is obviously bradycardia. Here I don't see the RR intervals which are regular. So you count the number of RR intervals. It's almost 5 RR intervals. So it's 30 rate. So and then do I see P waves? Yes, I see P waves. Is every P wave followed by a QRS? No, I see a P wave here. And then not every P wave is followed by a QRS. There is obvious PR prolongation, whether it's a fixed prolongation or if it's a progressive prolongation. So there is no progressive prolongation. It is not fixed also. It's completely dissociated. So I'm looking at a complete heart block. Okay. So PR prolongation, and there is obvious no relationship between the P and Q waves, which is AV dissociation. Okay. So first and foremost, he's on metoprolol. So stop that. And will atropine help? High degree heart block, it may not be so effective. Patient is symptomatic, so you will have to do the transcutaneous or transvenous pacing and then plan for a permanent pacemaker insertion. Okay. A 68-year-old male was found unconscious in the backyard in the morning. He's been missing for approximately 6 hours. He was reportedly going to check on a power outage, and on arrival, he was brought to the ER, drowsy, pale, cold to touch. So this is the ECG. So Osborne waves, yes. So the rate, rhythm, axis, and then you find a J point elevation, a positive deflection in almost all the leads, okay? Especially in almost all the chest leads, and usually it's more prominent in the precordial leads. The height of the Osborne wave is almost proportional to the degree of hypothermia. So these are the findings you can appreciate in hypothermia, okay? So P wave, PR prolongation, ST segment, T waves, and other findings. Okay, it can be a third degree heart block also in hypothermia. So these findings you can appreciate in hypothermia. So we have discussed 10 ECGs, but this is the list of ECGs you can never go wrong and you should be able to appreciate. So this is an extensive list, and beyond this also you can have ECGs. So I know you all must be tired of ECGs, but we'll not be breaking. So we'll skip on to the next topic if you're tired. So ABG interpretation, this also needs a stepwise approach similar to your ECG. There are no shortcuts, okay? Similar to the ECG. Always look into, as I told you, like look into the name, why it was taken, clinical scenario. Here also always interpret with the clinical scenario. That is something very, very important. When you're interpreting the ABG, consider two aspects. One is oxygenation, other one would be acid-base aspect, okay? And before going into interpretation, check for the validity. So how will you check for the validity? So measure the hydrogen ion concentration. How will you measure? So this is the formula you all will be knowing. So that is 24 times of PCO2 divided by bicarbonate. So if you find this is the table, which obviously becomes little difficult to remember, but at least when you're mentioning, when you're given an ABG, mention, I'll check for the internal validity of the ABG. Okay, so if you are, and with this, if you have a hydrogen ion concentration of 40, your pH should be 7.40. If it is 100, then your pH is going to be even less, okay, 7.0. Okay, if it's going to be somewhere around, it depends actually. So it depends on the hydrogen ion concentration. So in short, if you don't want to use this formula, in short, and you have the table here, for example, if you have a patient with 7.35, you take the last two digits, 80 minus the last two digits. So if it is 7.35, then you minus this 80 minus 35. So somewhere 45 you'll get. So 45 will be the hydrogen ion concentration. So you can check it up with this. So 45, your pH should be 7.35. See whether it's corresponding. So that's a short method. So consider the oxygenation prior. First, whether it's type 1 or type 2 respiratory failure, look into the PF ratio, whether the hypoxemia, whether it's 100 to 200, 200 to 300, or whether it's normal. So check in for the PF ratio. So always look into the FiO2 ratio. Also, what FiO2 the patient, the ABG has been taken. Next one, look at the AA gradient. AA gradient is nothing but the alveolar arterial oxygen gradient. So how will you calculate the alveolar oxygen? That is by the alveolar gas equation. So you all must be familiar with this: atmospheric pressure minus the barometric pressure of water vapor multiplied by the FiO2. And you have to subtract the PCO2 divided by the respiratory constant, which is going to be 0.8. Okay, from this you can calculate. So how much you can accept this AA gradient? Up to 15 you can accept. Okay, it also depends. It varies with age. So you have the formula age plus 10 by 4, or there's another formula age by 4 plus 4. So either you can follow any of these formula. So age plus 10 by 4 we can consider. So normal will be less than 20. Okay, 15 to 20. So why is it important? Okay, the AA gradient is important because you can diagnose whether it's either due to a lung pathology or due to something else. The AA gradient will be normal in conditions like somebody with a CNS pathology, obesity, OSA, or a drug overdose, or some neuromuscular weakness. So in this scenario, the patient might be hypoxic, but then the AA gradient will be normal. Okay. The AA gradient will be abnormal in most of the other conditions like shunt, VQ mismatch, dead space, and all those conditions, it will be abnormal. Okay. So next, we are coming to the acid-base aspect. So I hope everybody will be aware of this. So pH, acidemia, alkalemia, and then look into the PCO2. respiratory acidosis, and then alkalosis. Metabolic, look at the bicarbonate 22 to 26, whether it's lesser than 22 acidosis, more than 24 and 26 alkalosis. Okay. Next important step is which is the primary disturbance. Look at the pH and PCO2. Both are going in the opposite side. That means you're dealing with the respiratory, which is a primary disturbance. Rome, remember this mnemonic. Respiratory opposite side, pH and PCO2. pH and PCO2 moving together. That is metabolic. Okay. This metabolic. Okay. And then if the primary pathology is respiratory, your kidneys will try to compensate by either retaining bicarbonate or excreting more bicarbonate, which happens slowly. The kidney compensation will be slow, whereas the lung compensation is going to be fast. So next step would be looking at the compensation form rates or the formulas. Okay, if it's a metabolic acidosis, you have the Winter's formula, which is 1.5 times the bicarbonate plus 8 plus or minus 2. Metabolic alkalosis, you have this formula, that is expected PCO2 is equal to 0.7 into bicarbonate plus 21 plus or minus 5. Okay, if it's a respiratory acidosis and if it's acute or chronic, the compensation will be different. Okay, in acute scenario, for every 10 millimeter increase in the PCO2 above 40, your bicarbonate will increase by 1 millimoles. Okay, if it is a chronic condition, for every PCO2 every 10 above 40 millimeters, your bicarbonate will increase by 3 to 4. Similarly, in respiratory alkalosis, acute scenario, for every PCO2 decrease by 10 below 40, your bicarbonate is going to decrease by 2. Respiratory alkalosis, it is going to decrease by 5. So this is calculating your bicarbonate, okay, your expected bicarbonate. But if you want to look at the pH, you can use this formula also. So every PCO2 increase above 40, you'll have to kind of know this factor of 0.08 in an acute scenario. In case of chronic, 0.03. So if it is respiratory acidosis, you will have to minus this from your pH 7.40. If it is kind of alkalosis, you will have to add it to that, and that will be your expected pH. So you will have to see the expected pH and the actual pH, and then you will have to interpret it. Next step would be, so for you have known the primary disturbance, you have calculated the compensation, whether it's compensated, partially compensated or not, whether there is an additional disturbance, and then look into the anion gap. Will you calculate the anion gap only for patients with metabolic acidosis? No. Even if the ABG looks normal, you'll have to calculate the anion gap. And anion gap always corrected for the albumin. So sodium minus chloride and bicarbonate. Okay, normal is 8 to 12. We are ignoring the potassium here. So causes of high anion gap metabolic acidosis, normal anion gap, we'll look at it later. So corrected anion gap. So what is the factor? Just remember the factor 2.5. So normal albumin is 4, okay? If your albumin is 2, so 4 minus 2 will be 2. 2 multiplied by 2.5 will be somewhere around 5. So it is going to be so you have to, if your anion gap is 7, you'll have to add that, okay, correction factor for the albumin. So this is the formula for the corrected anion gap. Next would be calculate the delta ratio. So what is the delta ratio? This is the delta anion gap divided by the delta bicarbonate gap. If the delta gap is less than 0.4, it's pure nagma. If it's 0.4 to 0.8, it's mixed nagma and hagma. If it's 0.8 to 2, it's pure high anion gap metabolic acidosis. If it's more than 2, it could be mixed high anion gap along with a metabolic alkalosis or a respiratory acidosis. So this is something that you have to kind of remember, delta ratio. So we'll take the ABGs one by one. 35-year-old woman, community-acquired pneumonia, brought with confusion, decreased urine output 2 days. TLC 24,000, urea 55, creatinine 1.2. X-ray shows right lower zone infiltrates. She's on NIV 0.45 FiO2, pH 7.10, PCO2 20, PaO2 102, bicarb 5. Anybody who wants to mention the diagnosis? So we'll go ahead. So first step, validity, then oxygenation, AA gradient, then primary disturbance, that's going to be acidemia, and then it is pH and bicarb going on the same side. Okay, this is metabolic acidosis, and then you calculate the compensation. So this is 1.5 times the bicarbonate plus 8 plus or minus 2, that is additional respiratory acidosis is also there. Then you calculate the anion gap. So anion gap is 138 minus bicarb and then the chloride. Okay, the chloride is 109. So 138 minus bicarb and chloride, that is 26, which is a high anion gap. Look at the albumin. Albumin is 4. Then go into the delta ratio, which is nothing but anion gap, delta anion gap by delta bicarbonate, which is 0.8. So you have a 0.8. So you have this interpretation of delta ratio. So if it is 0.8, it could be a mixed disorder. Okay. So remember this delta ratio. So the final diagnosis is primary high anion gap metabolic acidosis, and there is a normal anion gap metabolic acidosis also, which is combined, and there is respiratory acidosis as well. So what is the reason for this? Next step, you should give the differential diagnosis also for this patient. So you have a high lactate. So metabolic acidosis, which could be explained here, the blood pressure is normal. I could see the lactate that is high. The patient has an acute kidney injury as well as sepsis that is going on. So that could be the reason for the high anion gap metabolic acidosis. So you have to know the causes of high anion gap metabolic acidosis and normal anion gap metabolic acidosis. Remember the mnemonic. A, cat mud pile, okay, methanol, uremia, DKA, propylene, glycol, all the alcohols, isoniazide, iron, ibuprofen, and then starvation, aspirin. So these all carbon monoxide, cyanide, caffeine, theophylline, okay, all these things, okay, mud piles. So this is something you have to remember. So non-anion gap metabolic acidosis could be due to most commonly diarrhea, fistulas, uretrosigmoidostomy, okay, cholestyramine, and then it can be HCl intoxication. Patient who was on normal saline infusion, high chloride, okay, and dilutional acidosis can be there. And renal loss of bicarbonate, which we see in renal tubular acidosis. It can be proximal, distal, or hypoaldosteronism. Okay. So causes of high anion gap, low anion gap, and negative anion gap. Where will you get high anion gap? We saw those conditions wherever you get the high anion gap. Actually, the other things which can cause a high anion gap would be hyperalbuminemia, hyperphosphatemia, and paraproteinemia. Okay, these are some of the conditions which can cause. Also, if there is a decrease in the unmeasured anions, hypoalbuminemia, multiple myeloma. So bromide and iodide can be misinterpreted as chloride, okay, in some analysis. So that can be one of the reasons for low anion gap. So when you're talking about low anion gap, remember immunoglobulins, okay. So monoclonal IgG, immunoglobulins can be one of the reasons. Bromide, lithium, iodide, hypercalcemia, hypermagnesemia. So this is the reason. These are the reasons, okay. And lab errors causing hyperchloridemia or underestimating the sodium. So this is the reason for low anion gap. Negative anion gap, almost the same conditions, multiple myeloma, bromide, iodide intoxication, and lithium chloride intoxication. So also remember, whenever you're dealing with a metabolic acidosis, anion gap, delta gap, and especially the clinical scenario includes something like a toxin intake or something that is suspicious, osmolar gap also you have to check. So this is the formula for checking the osmolar gap. So normal will be 10. So if it's more than 10, it indicates there can be some hyperosmolar substances in blood like ethanol, toxic alcohols like methylene glycol, or some kind of pseudo hyponatremia caused by hyperlipidemia and triglyceridemia. So there's a list of conditions which can cause a plasma osmolar gap. So somebody has asked, if it's a venous sample, how will we know? By 80 minus formula. So venous sample, you have to look into the SaO2. So you will have to know whether it's a venous or an arterial sample. Next, that 80 formula is, I'll mention at the last once again. Okay. So saturation gap. So saturation gap is the noted SpO2 minus the SaO2. If it's more than 5, it indicates there is some other pathology like a methemoglobinemia and carboxyhemoglobinemia, where the saturation will be, SpO2 will be noted as 85 only. You'll note a SpO2 of 85 only. So in these conditions like methylene blue, indigo carmine dye, so all these conditions you can have a high saturation gap. Next ABG, a 50-year-old COPD with shortness of breath, cough, fever, 2 days comes to the ER. So FiO2 0.24, pH 7.16, PCO2 72, PaO2 58, bicarb 27. So these are the electrolytes and albumin. Interpretation. So it's obviously validity. So mention step by step, check the validity, PF ratio, AA gradient, and then AA gradient is obviously increased. This is acidemia, and then PCO2 is increased. So pH and PCO2 opposite direction. So this is respiratory acidosis. And for every, whether it's an acute or chronic, you can use the either pH based formula, or you can calculate for every 40, every 10 millimeters increase above 40. So it's almost 3 times above 40. So 3 times. So it is going to be 3.2. So your factor is 3.2. You add it to the bicarbonate. So 24 plus 3 is going to be 27. So this will be the expected bicarbonate. So your expected bicarbonate is 27. What is the patient's bicarbonate? It is 27. So it's almost the same. It's a primary respiratory acidosis. Anion gap, normal. You calculate the delta gap. So delta gap, again, anion gap minus 4, 12 minus 4, and then bicarb 24 minus 27 minus 24. It's going to be 3. 7 by 3 is going to be 2.3. So 2.3 above 2 is going to be Hagma plus a metabolic alkalosis. So what is the diagnosis of this patient? It is predominantly a type 2 respiratory failure. It's an acute exacerbation of COPD in this patient. Okay, causes of respiratory acidosis. Again, you should know the causes of respiratory acidosis, whether it's inadequate ventilation, or it's overproduction of CO2, or increased intake of carbon dioxide. So these are the various causes of respiratory acidosis that you can know. So inadequate ventilation, overproduction of carbon dioxide, increased intake of carbon dioxide. When does this happen? Actually, this can happen due to rebreathing or insufflation of carbon dioxide into the body cavity. So these are some of the conditions. Dead space, and then depressed ventilation. So central nervous system depression, neuromuscular disorders, or lung defects, or some abnormality. Overproduction can be due to thyroid storm, malignant hyperthermia, pheochromocytoma, early sepsis, and all those things can cause respiratory acidosis. Next ABG, 40-year-old comes with tachypnea, lethargy, tinnitus, history of drug overdose, pH 7.32, PCO2 15, PaO2 90, bicarbonate 10. And then these are your electrolytes, and then albumin is normal. Oxygenation seems to be adequate. Patient is on room air, PaO2 is 94. And then patient is acidemic. So pH is low, bicarb is low. So this is a metabolic acidosis. So compensatory formula, Winter's formula, 1.5 times bicarbonate plus 8. It is a 23 is your expected PCO2. What is the PCO2 over here? So it is 15. So this is a respiratory alkalosis which is going on. So, and next anion gap should be calculated by sodium minus chloride and then bicarbonate. So you have an anion gap of 26, which is high. Then calculate the delta ratio, anion gap per delta anion gap, that is 26 minus 12 divided by 24 minus your bicarb, which is 10. So you have a delta ratio of 1, which is pure high anion gap metabolic acidosis. What is the reason? It's a primary metabolic acidosis, okay? Primary metabolic acidosis, which is predominantly high anion gap, purely high anion gap, along with some respiratory alkalosis as well. So this is a patient with a drug overdose. So in case if you're given serum osmolality, you'll have to check in for that, okay? And whatever your calculated one is with the formula, which involves the glucose and the urea and sodium. But what the actual thing that needs to be done in the lab is with a freezing point osmometer. Most of the labs do not have that. So you'll have to ask whether if it is done with a freezing point osmometer. And then the actual noted laboratory value of the osmolality and then your calculated osmolality, you'll have to minus, okay? And also saturation gap. 56-year-old COPD presents with diarrhea, abdominal cramps, decreased intake, BP 90/50, a heart rate of 110, FiO2 0.2, pH is 7.22, PCO2 30, PaO2 62, bicarb is 10. So obviously this is acidemic, pH is low, bicarb is low, same side. So this is metabolic acidosis. Winter's formula, you have a expected PCO2 of 23, wherein your PCO2 is almost 30. So this is associated respiratory acidosis. And then there is a anion gap, which is normal. So calculate the delta gap. So your anion gap is 7 minus 12 minus 7 and 24 minus your bicarb 10, which is going to be 0.3, which indicates a normal anion gap. So this is a completely normal anion gap metabolic acidosis with some amount of respiratory acidosis in this patient. So there is also some abnormal findings, high lactate, and then this patient had a diarrhea. So the reason could be diarrhea related. Normal anion gap, we saw what are the reasons. So it is diarrhea. And why is this high lactate? It could be due to volume depletion. Next ABG, 36-year-old primary IVF treatment, gestational diabetes mellitus, 1 hour post cesarean delivery, developed breathing difficulty, hypotension, requiring mechanical ventilation and vasopressor support. She is on FiO2 of 0.6, PEEP of 8. Echo done showed 35% EF, which is new onset, and X-ray perihilar infiltrates. Okay, the chloride is somewhere around 100. So this is the pH. pH 7.29, PCO2 34, bicarb is 16. And then what other abnormalities? You see a lactate of 13, glucose 261. Okay. So some electrolyte abnormalities are also there in this. So primary, there is a metabolic acidosis, pH and bicarb, same direction, metabolic acidosis. Apply the Winter's formula, 1.5 times bicarbonate plus 8 plus or minus 2. So 32, 30 to 34 is almost normal. There is partial compensation, respiratory compensation appears to be normal. Anion gap, you calculate sodium, 140 minus bicarb, which is 16, and chloride, which is 100. So you have a high anion gap, that is 24. Okay, delta gap is 1.5. So there is a high anion gap metabolic acidosis in this patient. Okay, two things that needs to be noted: glucose and lactates, that is abnormal. Primary high anion gap metabolic acidosis, probably high lactate due to cardiogenic shock, maybe a peripartum cardiomyopathy. High sugars, other differential would be DKA, high ketones. So you have to ask, okay, I'll check for the ketones as well in this patient. So what are the causes for high lactates? So this is something you have to know. Lactate is something very important in the ICU. The type of lactic acidosis, type A, B, and B, 1, 2, and 3. So type A is mostly ischemic or hypoxic. So septic shock, mesenteric ischemia, hypoxemia, carbon monoxide poisoning, cyanide, you get type A. Type B is non-hypoxic. It is secondary to renal, hepatic failure, or malignancy. Like patients with CLL, AML can have high lactic acidosis due to some other issues like high cellular consumption and all this. B2 is due to mostly drugs, toxins, okay? Thiamine deficiency, seizure is B2, okay? Toxins like salicylate, ethylene glycol, and then propylene glycol, paraldehyde, and drugs like isoniazide. So drugs you have to remember. So linezolid, isoniazide, iron, metformin. So all the antiretroviral drugs, most of the antiretroviral drugs can cause lactic acidosis. And 3 is inherited disorders, mitochondrial disorders, muscular dystrophies and all, type 3, okay? So 36-year-old polytrauma, SDH, rib fractures, liver laceration, BP 80-50, NRBM 10 liters, okay, tachypneic, pH 6.9, PCO2 26, bicarb 5.8. Okay, so these are the main values. Look at the other findings also. Okay, base excess. Trauma, you have to note the base excess because it denotes the shock actually. Your classification of shock depends on this also. So, and then hemoglobin 2.9 and potassium 5.1, glucose 18 millimoles per liter. Always note the values, okay? 18. So here, glucose, the limit is 5.5. Lactate 16. So how will you interpret pH 6.9 acidemia? Bicarbonate is somewhere around 5, okay? Then it is metabolic acidosis. Calculate with the Winter's formula, 1.5 times bicarbonate plus 8 plus or minus 2. Okay, how is the respiratory compensation? So there is a respiratory, your expected PCO2 is 15, there is additional respiratory acidosis, anion gap is high, and delta gap, there is hagma. Okay, so there is high anion gap metabolic acidosis with respiratory high lactates. So what are your differentials in this? Additional findings, mention the additional findings. Okay, anemia, hyperkalemia, hyperglycemia. Reason could be hemorrhagic shock, obviously, polytrauma patient, hemorrhagic shock, and this could be stress hyperglycemia in this patient. 60-year-old CCF, congestive cardiac failure, admitted with pulmonary edema, treated with antiplatelets, antihypertensives, diuretics, 6 days, planned for ward shift. And this ABG is done just prior to ward shift. Okay, pH 7.54, PCO2 of 46, bicarb is 39, and then lactate seem to be normal. So no other much variations. So this is obviously alkalemia. So PCO2 is 46 and bicarb is 39. pH and bicarb goes on the same side. It is metabolic. So alkalemia, metabolic. So this is metabolic alkalosis. The compensation formula is 0.7 times bicarbonate plus 20 plus or minus 2. So you have the expected PCO2. Expected PCO2 is 46 to 52. So you have almost in the same range. It's a compensated metabolic alkalosis. Here also you have to see the anion gap, which is normal, and which is one normal anion gap, and the delta gap. Delta gap mentions 0.9 is 0.9, which indicates high anion gap. So this is a compensated metabolic alkalosis, probably due to the patient has been treated for 6 days with regressive diuresis for pulmonary edema. That could be one of the reasons for metabolic alkalosis. So when you are given this ABG of a metabolic alkalosis, you will be asked questions related to this reason for metabolic alkalosis. One is renal and GI. It could be either due to loss of hydrogen ions or gain of bicarbonate. So loss of hydrogen ions from the GI tract could be due to vomiting, aspiration, congenital chloriduria, villus adenoma. Okay, in renal, diuretics, Gitelman, Barter's, mineralocorticoid excess or contraction alkalosis. Bicarbonate gain will be due to contraction alkalosis and milk alkali syndrome. So if you have to follow a proper algorithm for diagnosis of metabolic alkalosis, you have to know whether it's a chloride responsive or chloride Unresponsive metabolic alkalosis. Chloride responsive is less than, when the urine chloride is less than 20 milliequivalents. It could be due to all of these etiologies, mostly vomiting, diuretics, post hypercapnia, and all the GI loss. Okay, it is chloride responsive. If you substitute with normal saline, mostly it will get corrected. So this is chloride responsive. Chloride unresponsive when the urine chloride is more than 20 milliequivalents. So then you check for the urine protein also. Sorry, urine potassium. Urine potassium, if it's less than 30, it could be due to laxative abuse or associated potassium depletion. In this scenario, you replace potassium and then correct the metabolic alkalosis. If the urine potassium is again more, then look into the BP. Okay, BP is normal or low, it is Barter's or Gentleman. If it is high, again check for the plasma renin and then aldosterone and cortisol. So all these will give you a differential diagnosis of various things. If plasma renin is low, then it means aldosterone is high, primary aldosteronism, or adrenal hyperplasia, Liddles or licorice. Licorice is nothing but herbal ingestion, which is similar to aldosterone. And then high cortisol, Cushing's. And then you look in for any renovascular hypertension, like juxtaglomerular apparatus, tumors, and all that. So this is the algorithm for metabolic alkalosis. Next ABG, 80-year-old diabetic hypertensive dementia on oral hypoglycemics, insulin, skip few doses of medications, comes to the ER with altered mentation. Very easy ABG, pH 7.11. Bicarb is going to be 4.1, and then PCO2 14. Okay, here are most obvious findings: glucose 500, sodium 119, potassium 6. Okay, so this is something. So stepwise: acidemia, metabolic acidosis, Winter's formula, compensation. Okay, there is a respiratory compensation, which is appropriate. 14 is your expected PCO2, which is appropriate. There is a high anion gap. Okay, there is high anion gap. But one thing which you need to remember here, whenever your patient has a sodium of 119 and you have high glucose, you always kind of correct it and interpret it, right? But when you're calculating the anion gap, you actually take the actual sodium only. Okay. So corrected sodium, how will you get? For every 100, above 100 milligrams of glucose, you have a factor of 1.6. Okay. So it is 4 above 100. So 500 is 4 above 100, 4 factors above 100. So 4 into 1.6, that gives you a factor of 6.4. So you add this factor to 119. So 119 plus 6.4. So this gives you the corrected sodium. But then when you're calculating the anion gap, you actually mention the actual sodium. Okay, the actual sodium, when you calculate the anion gap, it is high. So calculate the delta gap. Again, it's a pure high anion gap metabolic acidosis. Okay, probably due to decay. Next, 28-year-old woman, Sjogren syndrome, not on treatment, recurrent kidney stones, muscle cramps, no diarrhea. She presents with a pustular lesion in the left mammary flank, fever 2 days, slightly tachypneic. Somebody in the ER decides to do an ABG. pH 7.29, PCO2 30, PaO2 95, bicarbonate 14. Okay. And this is the lactate, ketones are negative, so electrolytes. So these are the findings. So phosphate also you have. So obviously acidemia, metabolic acidosis, compensated. And then there is some amount of, when you calculate the anion gap. So anion gap is 7. So calculate it. Whenever you have a low anion gap, particularly you should be always you have to correct it for the albumin, especially when you have a low anion gap, you will have to make the correction appropriate. So even after correction, it is normal anion gap metabolic acidosis. Delta gap is also 0.4, which denotes a normal anion gap metabolic acidosis. So what is the reason for that normal anion gap? So how will you interpret? Is the patient on saline? Is the chloride level high? Okay, it's slightly high. Okay, that is one factor. Second one, diarrhea, any other kind of urethral sigmoidostomy, any other fistulas, any pancreatic fistula, anything is there in the history? No, I don't find anything. So what is the reason for this normal anion gap? So there is a stepwise approach. Okay, when you don't find any obvious reason and there is no obvious renal dysfunction also, okay, it's almost normal only for this patient. So you ask for a urine electrolytes and pH. So look for the urine pH, which is 6.2. Sodium is sodium 50. This is the urine values, okay. Urine sodium is 50, potassium 20 and chloride 40. You calculate the urine anion gap. Here you have to include potassium, okay, sodium plus potassium minus chloride. So here the anion gap is 30, which is more than 20. Okay, you have the cutoff of 20, which is positive. So pH and your urine anion gap, which is positive, that denotes a renal tubular acidosis in this patient. Which type of renal tubular acidosis? That you will have to look into various other things, okay? History wise, patient has Sjogren's, kidney stones, and then the pH, okay? pH is more than 5.5. So these three things, especially the pH more than 5.5, is type 1 RTA, the distal RTA, which, and also there is hypokalemia in this patient, okay? And here there is another catch in the question. There is refractory hypokalemia. So that is one thing that you have to note it. So this denotes with the, so this is a type 1 RTA, okay? Normal anion gap acidosis and type 1 RTA. So how will you calculate? So this is a stepwise approach. Look for hyperchloride excess and then see if there is any renal failure. There's nothing significant in a patient with normal anion gap. Always ask for the urine electrolytes and urine pH. If the pH is more than 5.5, it's distal. If it is less than 5.5, it could be proximal or type 4. Okay. Here, type 1 and type 2, usually you have a potassium that is low, hypokalemia, whereas type 4, you have hyperkalemia. Okay. So this is the difference actually, type 1, type 2 and type 4. So this is the mechanism, impaired potassium secretion. Here proximal bicarbonate wasting, and here and type 4 is hypoaldosteronism or resistance. The main differentiating factor in these three will be pH is high in distal, whereas pH is low in type 2 and type 4. Okay, and hyperkalemia will be there in type 4. History wise also you can kind of find out Sjogren stones, so all those things. So low phosphate will be associated in proximal. So management, treat the hypokalemia, alkali supplementation, type, and main thing would be treat the cause. So this patient on Sjogren's was not on treatment, okay? So you will have to treat the etiology. So 47-year-old woman is 4 hours post lap cholecystectomy, presents with severe upper quadrant shoulder pain, visibly anxious. The surgical team reports that the procedure was uncomplicated. Vitals tachycardic, BP slightly on the higher side. She's tachypneic, rapid shallow breathing, temperature is almost okay. And then SpO2 is normal. She's not needing much of oxygen. pH 7.6, PCO2 18, bicarbonate 21, and PaO2 is 126. Okay, this is obviously alkalemia, and this is pH and PCO2 go on the same side. So it is respiratory alkalosis and then compensatory formula. So for every 40 from decrease from PCO2, 40 decrease from the 40. So it is factor of 2. You can consider a factor of 2. So whether it's acute or chronic, this appears to be an acute disorder. So you have a factor of 2. So 2 times will be, it is 20. Okay. So it is going to be factor of 4. So 24 minus 4 will be 20. So your expected bicarbonate is going to be 20. So this is kind of partially compensated one only. It is predominantly a respiratory alkalosis. Anion gap is normal. Delta gap, high anion gap. Reason, Mainly, it is a pain, anxiety, post-operative patient. So respiratory alkalosis due to pain and anxiety. When you're dealing with respiratory alkalosis, first see whether the patient is hypoxic or not. Hypoxia can be one of the factors of respiratory alkalosis. Okay. And then because hypoxia stimulates the respiratory drive, and then it causes a high respiratory rate. Next one, looking for pain, anxiety. Some patients who have a pulmonary thromboembolism can also present with respiratory alkalosis as the first ABG. Okay, and rarely CNS lesions, progesterone. So these are the list of disorders that can cause respiratory alkalosis. Central nervous system, psychogenic, heat stroke, and any head injury, traumatic brain. You have this sympathetic syndrome, no, paroxysmal sympathetic syndrome, and then various drugs like salicylate, progesterone, so sepsis, all those things. Pulmonary factors, hypoxemia, pulmonary embolism, even asthma. The first ABG could be respiratory alkalosis as a predominant thing. So we have discussed most of our bedside calculations of ABGs. This is the Boston approach or the physiological approach. If you need to know what are the other modalities, like what are the other methods that you can analyze the ABGs. This is a very simple, easy to apply at the bedside and which is practiced commonly. Okay. The other method which you can be asked is the Stewart approach. Okay, you have to know what is this, and most of the time you will be asked about what is the strong ion difference, what is strong ion gap, what is unmeasured anions, unmeasured acids, and all those. So Stewart principle, what is the basic principle, and then how is it important? Okay, mainly in complex disorders, you want to understand what is causing the underlying pathology in this patient, whether it's an albumin effect or lactate or some other anions like any organic acids or toxins, which is causing the complex metabolic disorder. If you want to understand, the Stewart will be giving you an exact interpretation of it. So I'll just go short in brief regarding this. So you know in Stewart principle, so what are the independent factors, dependent factors, independent factors, ATO, PCO2, and strong ion difference. The strong ion difference is nothing but the strong anions minus the cations. Okay, strong positive charges, that is the anions will be sodium, potassium along with calcium and magnesium if you have those, and then minus chloride, your strong cations. This gives the strong ion difference. Okay, strong anions minus the strong cations. This is the strong ion difference. Okay, and this strong ion difference normal value is 35 to 40. If it is lesser than that, it is going to be acidosis. If it's more than 35 to 40, it is alkalosis. So you have to remember. And simple method, this is the equation, Stewart-Finn equation. So here you can calculate the unmeasured anions, the how much of unmeasured anions are contributing to the acidosis. So here your standard base excess is equal to the strong ion difference. Your lactate level is 1. Okay, the factor is also 1. So 1 minus lactate. The factor for albumin is 2.5, similar to your anion gap. So 2.5 times 4.2 will 4 minus albumin. So this is your albumin contribution. So lactate, your strong ion difference contribution, lactate contribution, albumin contribution, plus your unmeasured anions. This will be your base excess that you measure. Okay. If you want the unmeasured anions, that is your other acids that is not being measured, actually unmeasured anions, you will have to minus this contribution from the strong ion difference, lactate and albumin. Okay, so whatever the value that you are getting in the lab, like standard base exit, minus the contribution of all these things, will give you the unmeasured anions. Unmeasured anions usually less than 2 is normal. Okay, if it is more than 2, there is some hidden metabolic acidosis. Okay, you'll have to search in for whether it's a toxin or any other organic acid. So this is a simple stepwise approach that I have kind of done it. Okay. So this patient has a pH 7.25, PCO2 28, bicarb of 11. And these are the electrolytes, albumin and lactate. So you calculate the strong ion difference. So it is 42. It's more than 40. That means alkalosis. If it's less than 35 to 40, it is acidosis. Okay. And the standard base excess that you get, and then contribution of everything like strong ion, lactate, and albumin. This you can, this is the formula actually. So everything you can substitute in this. So the contribution of the strong ions will be 7. The contribution of lactate will be -2. 1 minus 3 will be -2. Contribution of albumin will be 2.5 times the difference in albumin, 3.5 times. The sum of the unknown effects will be 8.5. So, and this you minus it from you detect it from the standard base excess. The standard base excess is -14. Okay. That means already you know that the patient is acidemic. So you are removing the contributions of strong ions. You are removing the contribution of lactate and albumin. So if you remove that, if you add on this contribution, you have almost like 23. So this is a large unmeasured anions. So how will you interpret this? This is a high anion gap, metabolic acidosis, large unmeasured anions. Lactates only explain 2 milliequivalents. Actually, there is hypoalbuminemia, which is contributing an alkalinizing effect, and the strong ion difference, which is also alkalinizing effect. So there is a major contribution from an unmeasured anions. So this could be due to anything like ketones, toxins, or any other acids. Okay. So we have my sources that I've looked into. So these are the sources. So completing the session. Thank you, everybody. All the best to you all.